Dr. Hajela, my question for you today is, lots of people today use the term substance use disorder rather than addiction. What do you think?
Well, there is a big push to remove the stigma from addiction and mental health problems. And there are a number of people who still consider addiction a bad word, because just the word addiction, people consider it to be filled with shame and a negative connotation, which is ironic because the marketers around us have been using the word addiction in so many different ways, such that they're actually promoting it as a good thing. Like they say, get addicted to this, or get addicted to my product. My product is so good that it's addictive, you'd want to use it over and over again. So there's a real schism in our society about the word addiction. But at least the term substance use disorder, I can say, has been invented by the American Psychiatric Association in their manual called the Diagnostic and Statistical Manual, which is in its 5th edition. And the history of that term actually goes back a little ways. That when psychiatry moved away from using the word addiction, they tried to classify substance use disorders because people recognized addiction to be related to drugs or alcohol. So they said substance use disorders were of 2 kinds. One kind was called substance abuse, which is an earlier stage problem where a person starts using a substance and they use it to excess, but they don't have the compulsion or the impairment of control or craving associated with it. So people used to say that substance abuse can happen when someone is continuing to use a substance and they're having adverse events, but they don't have compulsion, craving, or impaired control. That is called substance abuse. Then the term substance dependence was used to describe where people do have compulsion, craving, and impaired control. So if you know the ABCDE of the disease of addiction definition, then you can recognize that A, B, and C, which is inability to consistently abstain, impairment in behavioral control, and C, craving, are part of that definition of dependence, which is also analogous with addiction. Now, unfortunately, when DSM-5 was being put together, people thought that let's remove the distinction between substance abuse and substance dependence and call everything substance use disorder, because people thought that that's a less stigmatizing term. But in my opinion, that actually has created a bigger problem, because for some people who want to minimize the problem, they say that it's just substance use disorder and you can get educated and then you no longer have a substance use disorder, which is actually true for substance abuse, but it's not true for substance dependence. And interestingly enough, the World Health Organization and the people who have developed the International Classification of Diseases, and they are the holders of International Classification of Diseases, they have said no, we do not want to get rid of the term substance dependence. We do want to get rid of the term substance abuse, which they have tried even before. So substance abuse is better described now as hazardous use, which is episodic problem substance use, or harmful use, which is regular substance use that is causing harm. And then there's this phenomena of dependence or addiction. Now, World Health Organization and International Classification of Diseases still have stuck to the word dependence as opposed to addiction, although most of us in the field who recognize this distinction will sometimes use the word substance dependence and addiction involving substance synonymously. But if you can see that everything that we've been talking about says that addiction is a brain disease, it's a disease that is bigger and beyond substances. So calling it substance use disorder is really minimizing the nature of the problem. A, that you're using hazardous use and harmful use in the same category as someone who's got addiction involving substances, who is substance dependent in International Classification of Disease terminology. So you're lumping that together. And you are missing the point that even after someone stops using substances, they still have the disease of addiction in their brain that requires treatment. Because if people just use the behavioral criteria for substance use disorder, A, they may not appreciate the severity and the amount of treatment resources that substance dependence requires or addiction requires for treatment, and you totally miss the point that even after you've stopped using substances, you still need treatment for the disease, because the disease manifests in many different ways. So that is the biggest problem in using the term substance use disorder, that it misdiagnoses people and it undermines their ability to get proper treatment. Unfortunately, it is a very tricky idea for people to embrace, because so many people are still focused on substance use disorder, to the extent that a lot of people are focused on helping people control their substance use instead of stopping it. And that's where, again, people who have hazardous use or harmful use problems, we know through education they can get to some degree of control or lower risk use. But people who have dependence or who have addiction involving substances, definitive treatment requires abstinence, which everybody in many ways agrees on. But there again, the people who subscribe to the notion of substance use disorder, they don't want to talk about addiction, they don't want to talk about the disease beyond substances, and they get focused on harm reduction and mitigating the use of harm related to substances, and they try and put control measures on it. Now, I'm not against that strategy, but I try and emphasize that harm reduction is a means to an end, it's not an end in itself. Because when it's made an end in itself, meaning this is an alternative, in my opinion, people are being sold a rotten bill of goods. They're being done a disservice. Because I, for one, as a clinician, feel very strongly that a doctor's job is to give the whole information and then give the person a choice, that here are your options. If you're going to choose harm reduction right now, hopefully you'll remember that this is a much more serious disease. We can embark on harm reduction and then see how things are going to go. Or the person says, no, I've suffered enough, I've tried to control it, and I've gone to those programs that have tried to help me, and now I want to embrace abstinence. And then it becomes really important for me as a physician, as an addiction physician, to help them appreciate that even after they have stopped using substances, because when they stop, they have to go through withdrawal, and they have to learn about the cycle of intoxication and withdrawal that drives that aspect of the disease of addiction. And then they learn as to how to address the psychosocial, spiritual parts of the disease and the biological parts of the disease, so that they can have a healthier quality of life that is now substance-free. In that regard, even with harm reduction, if we start on that end, we can still introduce recovery concepts if people are willing. So in a holistic framework, harm reduction and abstinence-based treatment is not dichotomous. Although with substance use disorder terminology, unfortunately, it all skews it towards the direction of harm reduction.
Yeah, I remember when I started prescribing methadone during my training with methadone prescription, I was told that methadone and harm reduction is the most successful, the most effective method of treatment. And even if the patient come and say, you know what, it is too much now, I want to wean off methadone and I cut down the dose. No, we tell them, we were trained to tell them, you know what, if you stop methadone after a year, there is the chances of relapse like 90%. If you stop after 3 years, the chances of relapse like 70%. But nobody at this time was offering them what recovery means, what you can do other than methadone. It was at the end. You are on methadone, this is your treatment, continue on it.
You're absolutely correct, and that was my objection, and that remains my objection, because in that framework it is classified as opioid use disorder. So even substance use disorder is further narrowed down, and often people will come that they have problems related to medications they were using, and or they were buying street opioids, and then they got into trouble. And of course, street opioids these days are very lethal, things like fentanyl or carfentanil that are illicitly manufactured. And it is important to appreciate that these are the illicitly manufactured drugs that are on the street, that are connected with the deaths, not prescription opioids. Although prescription opioids may be involved in some cases, but it is the illicit opioids that are contributing to the overdose deaths. And there's a tendency to say that, okay, this is just an opioid use disorder, so you can use methadone, or the other drug that is available is buprenorphine, and buprenorphine naloxone combination that people may recognize the names of Suboxone. So methadone and Suboxone as substitution for the opioids in a prescribed manner in a controlled framework was supposed to be, and still is touted to be, the definitive treatment. But I hope you can see that it doesn't really treat addiction. It is just treating opioid use disorder, but even opioid use disorder in a very narrow way. And if you're just trying to control the use, then relapse really would be 100%. So these figures that 90% and 70%, they actually are just made up numbers in some ways, because they're discounting the fact that some people in that time when they are on methadone or Suboxone spontaneously will try and choose a better way of life. What my pitch is that you don't have to rely on the patient naturally choosing. We do have the technology, we do have the means, we do have treatment resources where we can help those patients appreciate what the disease of addiction is. So we can actually get 100% remission while someone is on methadone and Suboxone if we can institute proper treatment, and then encourage people and or support them as they get better and more stable in recovery. They can start taking and tapering off the methadone and Suboxone, because methadone and Suboxone are not innocuous drugs. They do have an effect on the brain, and in that sense methadone even more so on the brain and other body physiology than buprenorphine, which is why people may recognize that now people are being encouraged to go on Suboxone much more than on methadone because of the chemical differences between the two drugs and the way they act on the body physiology. So it is a very complicated question, and I'm glad you're asking the question, and hopefully the listeners, if they have addiction involving opioids, that they don't get relegated and they don't accept the simple diagnosis of opioid use disorder, because sadly, even amongst our physician colleagues, there are some who think opioid use disorder is just opioid deficiency. I've heard colleagues say, oh, it's just like a diabetic needs insulin, that you need your methadone or Suboxone. And nothing could be further from the truth, because even with diabetes, we know that every diabetic doesn't need insulin. And that's where everybody who has addiction involving opioids doesn't need methadone or Suboxone. Like, we have other approaches to diabetes treatment, which is where we have other approaches for addiction treatment, and specifically for addiction involving opioids. Certainly amongst my patient population, there are many people who go opioid free, just as they go alcohol free and tobacco free and cocaine free, and they enjoy a healthy, happy recovery without any assistance from any other medication. Whereas there are other patients who may require some medication assistance for a short period of time or a long period of time, to the extent that the opioid antagonist called naltrexone, which is also considered a great anti-craving drug, it's an opioid antagonist, very effective for people who have addiction involving opioids, but also very effective in helping people who have craving of alcohol, in people with addiction involving alcohol, or it's also a useful aid in smoking cessation. It's also been effective for my patients who have addiction involving food or sex. And these are anecdotal reports based on my own clinical experience, but this is where we need more research in this area to see how we can use medications effectively and not just issue blanket statements like putting someone on a medication and saying to them, now you're on this for life, and if you go off of it, then you'll be in trouble. Unfortunately, this is the same thing that has gone on for benzodiazepines for the treatment of anxiety, where people get put on these medications and then they have side effects and they have problems, and unfortunately they're relegated to something for life, when really if they were treated properly and that symptom was assessed properly and they're given proper treatment. And again, benzodiazepines per se are not bad chemicals, but they need to be used. And if you ask the drug companies and if you use the product and read the product monograph, you will see that they were designed for short-term use. And that's the interesting thing in our society. We have so many medications on hand that are really there as a stopgap measure so that we can really address the physiological disturbance and treat whatever the underlying disease is in a more definitive way, rather than thinking that whatever medication we need as an acute intervention, that it is there for life. So that is the problem, and that's where we need a paradigm shift from substance use disorder to addiction. And that's where listeners and you may know that the term addiction medicine is something that is only about 30 years old. It was only in the late 80s that the American Society of Addiction Medicine came into existence, and addiction medicine just a few years later got assigned a code, ADM, which is how it's known, addiction medicine. And it is addiction medicine, not addictions medicine. It is addiction, meaning addiction is a primary disease, which is a unitary disease, which has a lot of manifestations. Because as soon as you put the S on, you unfortunately shift in the direction of substance use disorders, where people start focusing on just treatment of opioid use disorder or alcohol use disorder or nicotine use disorder, while missing the big picture that everybody who has addiction involving opioids has problems that go beyond opioids. Just as someone who has addiction involving alcohol, it goes beyond alcohol. And this is not a new idea, that people who know about alcoholism, and even if we go back to Alcoholics Anonymous, that was established in the 1930s in the US, that people who established the program recognized that treatment and recovery actually started with abstinence. And even now, 80 years later, there are a lot of people who think of AA as a way to stop drinking, when really AA, right from its inception, was a program, and still is a program, designed to help people live sober while they're learning more about their disease, which goes beyond alcohol. And if you read the big book of Alcoholics Anonymous, it clearly points out that alcohol is but a symptom of our disease. It's not the disease. But because the term alcohol is mentioned, it creates a lot of confusion. People get stuck on just alcohol as being the problem, rather than recognizing that the disease is actually addiction.
Thank you, Dr. Hajela.